Paul Kidwell from the Connecticut Hospital Association, and I'm here today to testify on the two certificate of need bills before the committee. Our comprehensive written comments on both bills are available for your review, so I'll be using my 3 minutes to highlight a select number of provisions. Related to the committee's bill, we support Section 1, which adds a CON requirement for any investment in a healthcare facility by a private equity company in which the private equity company acquires a controlling interest in the facility. We believe that this new oversight requirement, which focuses on investments that impact the controlling interest or managerial control of a hospital, is targeted and reasonable. Section 3 of the bill requires OHS to post notice on its website when it enters into agreed settlement negotiations, prevents OHS from granting intervenor status in public hearing related to a CON application filed by a group practice, and creates an expedited CON process for an application to increase licensed bed capacity. I wanted to focus on the third item, which allows for the expedited approval of licensed bed capacity. We support that notion. We're hoping that the committee would be amenable to actually making the OHS either approve or deny the request within 48 hours. And I'm happy to answer any questions related to our concern there. Related to OHS's proposed revisions, we oppose the continued use of policies and procedures in implementing statutory language. We think the regulatory process should be followed there more closely. We are opposed to the change to the limitation on termination of services. We believe existing statute is sufficient to ensure that both OHS has information related to a termination of services while also allowing the facility to determine if such services will in fact be terminated. Finally, Section 5 of the bill proposes that OHS may develop and implement an expedited process for certain determinations. We certainly agree with the general approach, but think that it should be much more targeted, and that the expedited process should specifically be used for the establishment, transfer, or expansion of behavioral health and substance use disorder treatment services, the acquisition of imaging equipment, and the termination of services. Keeping in mind Representative McCarthy-Vahey's comments from much earlier in the day related to making progress where we can, I do want to say, we generally believe that the CON process needs a much larger overhaul, and certainly have ideas related to how that can be accomplished. But in a number of areas, we would like to see the CON process prohibit OHS from requiring applicants to meet requirements or obligations that are not set forth in statute or regulation, streamlining CON by not requiring an application for relocation of outpatient services within the same municipality and other like services. And like I said, developing a CON process, an expedited process for those specific services I mentioned earlier. Finally, I'll note Section 6 of OHS's bill allows OHS to charge up to $300,000 to an applicant for the services provided by OHS. That currently exists in statute at $200,000. And so to the extent that we will be providing OHS with greater resources to do its work, then we would hope that that process would move more quickly than it currently does. So with that, I will appreciate your time and happy to answer any questions.
Thank you very much, Mr. Kidwell. And I'm not sure, I'm not able to get to your written testimony right this moment, but I will find it, and I know you have submitted that. Just to your point about the incremental change, some say Connecticut is known as the land of steady habits, and others say Connecticut is known as the land of incremental change. So to that point, have you experienced in the years that you've been doing this work, any years prior to my time on this committee, or perhaps even Senator Amwar's time on this committee, years where there has been a major overhaul of the CON process?
My time, Representative, is probably as limited as yours related to the CON process. And so I don't know of any time when there's been a major overhaul. My colleague Karen Buckley may be able to answer that question more thoroughly than I can. But I will say that in the last 5 years, we've had some major CON applications that from our view have taken much too long and have really had a negative impact on how healthcare services are delivered in this state. And we're currently, as an example of a current process undergoing, New York has already approved one of the CON applications in front of Connecticut OHS right now. They did it within 90 days of it being requested. So we think there certainly are reasonable questions to be asked, but it's taking far too long to come to decisions. Additionally, I think some of the applicants for CON are sort of practicing defensive CON medicine in that in order to preserve our right to appeal a decision, there needs to be a contested case, so a mandatory hearing must be called. And in the case where a mandatory hearing isn't called, OHS has the ability to call a discretionary hearing, but if they do that, we lose our appeal rights. And so what we see happening is either you try to get a mandatory hearing called in order to preserve your appeal rights, or you just hope that OHS doesn't call a discretionary hearing, say, on the 89th day before the 90-day period is up. And so we've got this situation where we need the timelines to be either firmer or clearer so that we don't see what we think is sort of an abuse of the timelines being used, either to delay or ask additional questions. So, of course, we're always happy to work with the committee on that. We think there are some meaningful improvements in the committee's bill that we certainly support, but do think there's more work to be done.
So thank you for that answer. The other question that I had is just about the termination of services. I mean, again, I have not reviewed your written testimony, but your suggestion is that basically the process seems to be working the way that it should be now. Is that a fair way to say what you're saying? Or because I think given some of the situations that we've seen, there are concerns because when you have intermittent service, you can't count on that. And of course, if I'm a pregnant mom and I don't know when that baby's coming, right, I'm not probably going to the place that, well, it's only open sometimes. When I'm in labor, I'm not checking to see which one is open. I'm going where I know it's available. So if you can speak to that,
sure,
that'd be great. So
we think for termination of services, that should be an area where an expedited process could be useful. To your point around whether the sort of uncertainty around service availability, certainly we think that OHS should have a review of that application, but it shouldn't be over 180 days. It should be a much more streamlined and efficient process so that all parties can then come to a decision about whether the service is going to be available or not. Now, in certain instances, and I know there's been testimony on this prior, it is difficult to find certain providers to provide certain services in certain areas based on the level of volume of those services, the level of need in the community. So those are hard decisions to grapple with for a community, for patients, for the hospital. So no denying that none of those decisions are made without study, but we think it should be done in a more expedited fashion.
Thank you for that. So if I were to give you the magic wand, putting aside that getting rid of CON altogether is not one of the choices, but if I were to give you the magic wand and say, you can design how we go about redoing the CON process. And I'm not suggesting that, just to be clear, I'm not talking about the content of that, but how would you go about having the conversation to redesign the CON process? What would that look like from your magic wand standpoint?
So I heard you ask this question earlier today too, so I'm hoping I'm prepared for it. But two things. I think it's identifying those areas today that require CON where an expedited process could be useful. So for my example, termination of services, that's a good place to start with expedited process. Two, it's making sure that the timelines aren't then used as a delay tactic, so that if 90 days is 90 days, it's 90 days. And that's all, both parties have to abide by the 90 days. It's not endless requests for information in order to come. That's what's killing the process, is that it's Paul Kidwell, what's the answer to this question? I give the answer to that question, and then there's another set of questions, and then there's another set of questions, and then there's another. It's endless until you get into a sort of an agreed settlement framework where you may be forced to agree to things that frankly aren't relevant to the CON that you applied for, just to get the process completed. So I think expedited process for certain services and making sure this statutory timelines are just that, and every party has to abide by them.
And I appreciate that answer. I'm going to go up a level in terms of how would you make that happen here? If you were, anywhere around the table, and when I'm talking about process, I'm not talking about the actual CON process, but who's having what conversations when and how. And I don't mean to put you on the spot, Mr. Kidwell, but I think it's a worthy conversation. In part, I'm asking because, as I've said in many different meetings, there's a lot of energy and emotion around the Office of Health Strategy. And there's a lot of energy and emotion, understandable frustration that people have had related specifically to the timelines on the process. And again, I think we all have talked about that here. We are interested in streamlining. We want to provide the kind of predictability too. So, that's part of my question.
One of the things you'll see in our testimony is I think it would be interesting for the committee or whomever, the group of individuals, to look at our neighbors in New York and see how do they efficiently do this within 90 days. That's what they do. They do it within 90 days. And they do it regularly within 90 days. And so what is the process that they've implemented that allows them to do that? Not arguing New York's healthcare system is perfect, but they have a process that seems to at least cut down on the length of time for those applicants to get answers.
Okay, well, we can talk more offline about that, and I think I am interested in that. I'm also interested in comparing apples to apples to see what kind of resources that office has to be able to do that work.
Absolutely.
And I think that's part of the conversation that's on us as a legislature, obviously.
It's, if you may, it's slightly off topic, but the sort of resources question and energy related to OHS, if you think about the cost growth benchmark, we compare ourselves a lot of time to Massachusetts. Massachusetts has a vastly better funded infrastructure for their cost growth benchmark program. So to your point related to resources and how do you resource a program that is supposed to be long lasting and meaningful, it does require a level of investment, I think beyond what we have done, which is investment in consultants. I think it's a different level of investment.
I really appreciate that answer because I could not agree with you more. And I think you're right that we will need to have a different level of investment. And it's a little bit of a conundrum because I think, some of the frustration leads to a desire to not invest, but it's in many ways the opposite is we are going to have to invest in the ways we need to be able, in order to be able to move this work along. But I really appreciate this conversation, and I am looking forward to talking together with all of you, with all of the stakeholders. I think you've heard us here talk about the fact that we spent a lot of time last year with the Office of Health Strategy to try and get to a certain point. We did not spend as much time talking with all of you, and I'm hoping that we can bring together the stakeholders, at least in this session, make some progress, but talking about and with a vision towards what's that long-term plan in terms of a more comprehensive look. Thank you, Mr. Chair.
Representative Zupkus. Thank you, Mr. Chair. Hi, thank you for coming. And my question was going to be if you had a magic wand. So I won't ask you to repeat that. But you did say, if I heard you correctly, that you get all these questions and they're never endless. And sometimes you have to agree to something that's not part of the CON. Could you expand on that for a minute, please?
So OHS, thanks for the question. So OHS has the ability to approve a CON, disapprove a CON, or what happens very frequently is say, well, let's have an agreed settlement on your CON, which then is generally a list of conditions for the approval. And in our estimation, OHS pushes for items in the agreed settlement that are not specifically related to the CON. So for example, they will say in the case of a change in ownership of facility, your commercial rates may not go above a certain percentage for a certain amount of time. We've testified quite vociferously that in Connecticut, Medicaid is underpaying, Medicare certainly underpays, and that is made up in the commercial market. And certainly OHS has a specific view about commercial payment. And in our view, they're then using CON to impose what, in the CON process, what they have not been able to do or advance through the legislative process.
Thank you. And so then my last question, in your magic wand, what would you do to prohibit that from happening?
So I think we would build it right into the statute. There's a list of things that require a CON. There's a list of things that OHS needs to review or take into account related to CON. We think that should be the list, and we would build into the statute a prohibition on anything other than that.
Thank you. And your written testimony has all this written out?
It does, and we are certainly happy to provide what we think are amendments to statutory language if that would be helpful.
Great. Thank you so much.
Thank you.
Thank you, Mr. Chair.
Thank you. I've also made an observation that as soon as somebody says CON, Senator Gordon appears. I was looking this way and I said CON and Senator Gordon is sitting there. Thank you. So, Mr. Kidwell, I have a few questions too.
Sure.
Earlier this morning, we were having a conversation with Commissioner Gifford, and in the last couple of years, things have changed within the department. Through the legislative body, we did put some more resources, and the different types of resources. In the past, if anybody left OHS, those spots were not filled. We are filling them as a state, and I think we have put more money into the department as well. And Dr. Gifford mentioned about the timelines changing quite a bit. What is the experience on ground on that part? I'm talking about the last couple of years, not prior to that. And I think in my conversation with various hospitals, there's a low-grade or a high-grade PTSD with OHS during the pandemic and perhaps prior. So I'm more focused on the last year or 2 years time.
Yeah. So thanks for the question. I think that certainly there is an interest, and Dr. Gifford expresses it, to attempt to move some of these CON applications through the process more quickly. And for certain services, that may be the case. I think and I noted it earlier, the concern is that applicants are we have a difficult time understanding how each application is going to be viewed by OHS and what tools OHS is going to use throughout the process, and where we may need to make sure we are availing ourselves of every right throughout the process. And so if we could improve the timelines so that applicants understand that there are hard and fast deadlines and those are going to be met, I think that would go a long way. One, to expediting the process from both sides, so that each party has a sort of specific expectation about what's going to happen and what they should prepare for. And so I think Dr. Gifford has attempted to focus her staff in moving some of these applications forward, but I think there are instances where it's still unclear how processes are going to be used.
Thank you. I'm going to give you a couple of important questions maybe you can answer. You know, everybody, and I've spoken about this passionately in another committee, that everybody talks about cost of healthcare. Nobody talks about cost of insurance of health insurance. And if the cost of healthcare is going up, the cost of health insurance is going up at a very different trajectory and much more steeper trajectory. Why is it that an insurance company can one day randomly say, we are not going to cover anesthesia? And whereas a hospital says, I want to add 2 beds or 5 beds, and then you have to wait for like 6 months or a year to get that yes, and they can just wake up one day and say, today we're going to stop anesthesia coverage. Can you expand on this and your frustration?
It's enormously frustrating because, so thank you for the question. There have been, days when we've come into the office and there's a hospital that they have reached their licensed bed capacity, and there are a lot of people in the emergency department. And there is no one to call to say, there's nowhere to put these folks. They have reached their licensed bed capacity. You can't call OHS and ask for an expedited process to increase the licensed bed capacity. And if you do, it's sort of we don't have the statutory authority to do that. And Senator, to your point, what is the hospital going to do in that instance? We have to treat the patients, or we look to divert patients from the ED to other hospitals that do have capacity, but we have to help manage the patients. To your point, we get edicts from the insurance companies all the time that say anesthesia is going to be changed next week, or we're piloting this in Connecticut to see what will happen. Right in the middle of someone's course of care, or as you're getting prior authorization for someone. Those are all things that have to be managed by the providers, by the hospitals on a day-to-day basis, while at the same time managing, I've reached my licensed bed capacity, what am I going to do? And it would be really nice to have someone at the state to be able to call and say, how can you work with me immediately to address the situation? And so that in our comments specifically to that is create this sort of temporary authority to allow for an increase in licensed bed capacity, and or to your point, create a ceiling. We suggest nine beds in 2 years that you can just increase, you can flex basically up to allow for those changes in volume.
So there's a mindset that the healthcare cost is primarily going up because of healthcare systems. And there's a lack of understanding that a number of costs are related to the insurance bureaucratic barriers. Who studies that, or who talks about that aspect and breaks it down? In other words, if Medicare Advantage requires you to keep the patients for much longer, and you're not able to provide a bed there, there's a loss to the healthcare system, and you need to have multiple different individuals who are fighting with the discharge planners and so on. So is there anybody who's doing data on that to see if that's increasing the cost of healthcare?
So I actually think that in the case of prior authorization, CMS over the last couple of years has actually taken a leading role in helping to improve that process, specifically in Medicare Advantage, to your point, because the federal government is paying for those all the costs that are going into that prior authorization. I will say at the hospital level, we have multiple people who spend all of their time getting prior authorizations and or fighting down codes from the insurance company, or looking for discharge. As you note, to the extent someone, it's interesting, you heard a lot of testimony about emergency department crowding today. Emergency department crowding is a symptom of the rest of the hospital not functioning efficiently, because there are people who do not need hospital level of care who have no other place to go. And that may be because of prior authorization, that may be because of a lack of someone at the home, that may be the probate issue that you're talking about today, and any number of issues. Fighting with insurance companies about whether a service is required and or prior authorization for someone to leave the hospital creates hundreds of millions of dollars in costs every year.
On another note, different topic. We have, in Senate Bill 7, we're asking for a hospital administrator to be licensed. You know the emotions around that for the people because of what we are seeing with Trinity, that they're controlling from Michigan, or they sent a person from Michigan who is going to be expected to do certain things. They are harming the well-being of our patients in our state more than any physician, nurse, APRN, PA, all put together in the state of Connecticut. Why can't we license them and have them training for ethics to be able to say no when their administrator from another part of the country tells them that they have to do certain things? They say, no, I cannot harm my patients.
So in our written testimony on SB 7, we talked more about this administrator role. A couple of things. As written, the bill would require a vast number of individuals in the hospital to be licensed. And it's unclear if you're considering an individual type of license for each of those individuals or not. Right now, hospital administrators in Connecticut are required to have worked in hospitals prior and have certain qualifications. Additionally, I believe, if I recall correctly, the bill says that all of this has to be done by October 1st of 2025. Karen will correct me if I'm incorrect. The ability to license that many people from the end of session to now is incomprehensible to me. And the consequence of that is you don't have people in the hospital who can do their jobs. So I think hospital administrators today certainly take their jobs very seriously. And there are physicians running hospitals today in Connecticut, non-physicians running hospitals today in Connecticut. And I think in both those cases, those administrators are operating their hospitals in a way that is mindful to patient care. And I don't certainly view licensure as a cure to what could be specific bad acting, certainly in one case in our state.
Okay, I hear you. I do think there's a role to have a license because if I hear these horrendous stories, like chief nursing officer comes to one place and says that we can put 2 people in the ICU today in the same room. So this patient is having dialysis, this patient has C. difficile. What do you mean? So it's like there are individuals who went into administration because they were not good at some of the clinical work, perhaps. And now they're making decisions on the patient's well-being, which is, when you hear about those, they absolutely do not make any medical sense or nursing sense. It's important to have some kind of a check and balance, because they say we are a private entity, whether it's a private equity or a not-for-profit. They believe that they can do anything to a person who walks through the doors. That's where the issue is, and this is administrators who are checked at times by the staff, the medical staff and the nursing staff, who have to pay by their jobs by stopping these individuals who feel that they are above any existing rules because they have their own little kingdom at times.
Yeah. So I understand the point, Senator. The Department of Public Health does license the hospital. The Joint Commission comes in and reviews operations of the hospital. There are conditions of participation for Medicare for the hospital. There are a lot of different reviews and checks to make sure that care is being delivered appropriately in a hospital today. So if your concern is specifically to activity going on in the hospital to ensure that safe, quality patient care is delivered, we have mechanisms today in place to ensure that that is happening. I think, as I noted, we don't think that a specific hospital administrator license is going to sort of get to what you're concerned with.
I'll stop back and forth on this topic, and the reason is that bad things are happening despite those checks and balances, so they aren't working. And we know many of the hospitals are being managed remotely or by administrators who are brought in by a helicopter. They come and do the things and then move to the next hospital. They destroy that one and then move to the next. That's what we have seen a pattern at times. So because that's what some of the larger centers are doing at this time across the country. And we're seeing a little glimpse of that in our state. Thankfully, we do have local hospitals with local leadership, and they are not renting the hospitals. They own the hospitals. They own the people in the community. So we see both mechanisms where, I'm just going to say it, Hartford and Yale are here to stay, and they do the right thing, and they are not doing the kind of things that some of the others are doing, who are being remotely managed. And there's a very big difference in both of them, both of them, the types of setups. Yale is doing good, Hartford is doing good, and the smaller hospitals that have local management, they're doing okay from the value, moral perspective. The others are falling up in the wrong direction, and that's why a bill like this would keep them in check. That's how I see it. But Senator Gordon.
Thank you, Mr. Chairman. Thank you for being here.
Thanks.
And I've read through the CHA testimony, so thank you for submitting it. I do have a few questions that struck me in the testimony, and I do appreciate the work that hospitals are doing. I know it's not an easy environment in general to operate in, but there is a couple items that I had some questions on, if I may. Mm-hmm. One is in testimony, it talks about what the CHA wants to consider, or in fact see if it could be put somehow into the bill, about streamlining the CON process by not requiring a CON for reduction in the number of inpatient or outpatient beds by 9 or fewer in a 2-year cycle. So if I read that, that means that no CON would be needed if 9 beds were determined by the hospital for whatever reason not to be needed, quote unquote. And then 2 years later, they can drop another 9. And every 2 years, they could just keep doing that if they wanted without a CON at all. Am I reading that correctly? Because one of the concerns I have is reduction in services. And that, to me, should be one of the things that we have CON for. I think in general, 99% of what CON is being required and processed by the Office of Health Strategy for expansion of services, one could argue may not be needed. We should be saying thank you for expanding services. But that just struck me as a little interesting. Sure. About CHA feels that no CON for reducing beds every 2 years on a 2-year cycle by 9 or fewer.
So I think it works in the inverse too, right? So it works with, if the hospital believes that it needs 9 more beds in that 2-year process, it would increase the bed capacity by 9 as well. I think what we're trying to get at is a process by which we can address fluctuations in volume without waiting for a CON application and process that may take up to 6 months. And so in the instance I was speaking of earlier, in which we're envisioning this, we've had instances here where hospitals have reached their licensed bed capacity, and they were not able to admit any additional patients until such time as the others were discharged, and their emergency departments continued to take patients, and/or we had to find other hospital or emergency departments to take those patients. There was no one to call in that instance to say, can we increase the licensed bed capacity so we can accommodate some of these patients? And so I think it's providing some flexibility within the process to allow a hospital to manage its beds in a reasonable way, and every 2 years seem reasonable to us. Certainly happy to work with you if you think there's a different standard.
I wasn't asking specifically about increasing. I personally don't think if you want to increase your number of beds, we should have a CON for it. We should say thank you for investing in increasing bed capacity. My concern is reduction. And I think any time a service is to be reduced, let alone terminated, we should have a review of that. I can cite, for example, inpatient labor and delivery at several hospitals, Johnson Memorial, Wyndham, that may be beneficial for the hospital systems. They're not beneficial at all for patients and the communities at all, which unfortunately kind of gets pushed to the side in the calculation made by Office of Health Strategy. But that's my concern, is a reduction. So every 2 years, 9 or fewer beds could just be reduced. So technically you can have a scenario of a hospital saying, we want to reduce 9, 2 years later we want to reduce another 9, and go accordingly and close a whole floor or a whole service. So that's just a concern I raised, but it sounds like...
Well, certainly, I think in that instance, Senator, if you were terminating a service, you would still need to go through the CON process.
Well, that gets to the second question I have, if I may, which is CHA has testimony that says that streamlining the CON process by not requiring a CON for the termination of inpatient or outpatient services due to insufficient patient volume or the inability to recruit or retain an adequate number of providers. So not only there would be not even needing a CON for that.
Yeah,
it just seems to be a continuum. And is that what CHA is interested in, that if a hospital decides it wants to be reducing beds every 2 years, not talking about increasing, but reducing, which reduces service, or eventually terminating a service, wouldn't then need a CON? Am I reading
I think
the testimony?
so. Yes, and I think we're interested in making sure that what we have seen recently is in our view, an insufficient understanding of the ability to offer services when no providers can be recruited to provide the services, and or there's no volume to support the service. And what we've seen are very lengthy processes by which those services were either required to stay open and or accommodations made. And again, we think there should be some general improvement in the process, and or the ability for hospitals to make decisions that fit their ability to provide the service.
No, thank you. I appreciate the testimony. I agree that there should be a stem to stern reform of the whole CON process, or the way at least it's being administered by the agency. But I do have serious concerns about reduction in services and not having some degree of oversight. It may work for the hospital, but it may not work for the community, especially rural communities where people then have to go to bigger hospitals that may already be overcrowded, not have enough beds or enough ER capacity. So I'm just concerned about how the dominoes fall if you streamline too much a CON process for reduction or termination of services. I think things can be streamlined, and I think other states do it. For example, other states can do it within 180 days for some real complicated decision making. But I just really worry about reduction and termination of services, just outright saying no CON. But I'm happy to have offline discussions about that. But that just raises concerns, to me, as far as that might go too far, and I see that as a proper way to make certain that we're trying to get services available to people in various parts of the state, taking into account that just because you may see point A and point B maybe X number of miles away, that can be quite a distance in the real world trying to get from point A to point B.
Certainly.
So I just wanted to raise those concerns to make certain I was reading the testimony correctly. But I appreciate you being here, and you do have a number of other good items in your testimony. Thank you, Mr. Chairman.
Thank you, Senator.
Thank you. Seeing no other questions or comments, we thank you for your testimony.